started in another country. So thank you. We're gonna, if you can go ahead and put your name in there, and I'm gonna say hello to Dr. Amy. I saw that she said hello. She's already signed up for a case presentation, so thank you so much for doing that. I want the rest of you to please consider doing a case presentation at a future session, and I'll ask again at the end. But just give it a few more moments and then we'll get started at noon. Okay, it's now 12. We're going to go ahead and get started. We have so much to do today, and we want to make sure we have time to have discussion. My name is Jody West. I want to welcome everybody. This is the third session of the PPCL Perinatal Mental Health Tele-Echo series. I am the coordinator. I want to go over a few housekeeping items with everyone before we get started. We ask that you put your name, email, and credentials in the chat box, excuse me, for attendance. This is going to be our agenda today. We're going to do our best to stick to this schedule. After I finish a few more announcements, Dr. Olivier is going to facilitate, and we're going to pass it on to then Katie Abear, who's going to present our didactic, and then Laura is going to present our case presentation today. The hub team will ask questions, as well as participants will ask us, give recommendations too, that will be sent to everyone following. But we're going to go ahead and start with introductions. Again, I'm Jody West. I'm the coordinator. I am the program manager for the PPCL program, which is the provider-to-provider consultation line. This ECHO series is the educational portion of PPCL. If you scan this QR code, it brings you to our registration. Once you register, we'll get information to you about our training updates, as well as opportunities to consult. It's a statewide, no cost consultation program for primary care and medical providers, healthcare providers, to reach out and get consultation on mental health needs of their patients, just because we know there's not enough services in the state. We offer pediatric mental health consultation, which is 0 to 21, as well as perinatal mental health support. So I'm going to give it to Dr. Olivier to continue with introductions.
Hey, good afternoon, everybody, and thank you for joining us again for the third session. Thank y'all for giving us your lunch break. I saw lots of different organizations represented. LSU Health Sciences Center, Maddie's Footprints, Volunteers of America, just to name a few. So thank y'all for coming back. I wish I had time to introduce everybody. But I'm Dr. Olivier. I'm a child and adolescent and adult psychiatrist in Lafayette, Louisiana. I work in private practice for Bloom Mental Wellness, and I am the facilitator for this session. So I will be making sure that we sort of run on time and on schedule. I'm going to go ahead and introduce the hub team. You met Jody West, who is our coordinator for this program. Katie, do you want to go ahead and introduce yourself?
Sure. I'm Katie Abear. I'm a licensed clinical social worker and also work in private practice at Bloom Mental Wellness, and I'm perinatal certified.
And Katie is also going to be presenting our didactic today, so thank you for that. And Dr. Zena, do you want to introduce yourself?
Good noontime, everybody. I'm Paula Zena. I'm a pediatric nurse and clinical psychologist. I've been very involved in the world of infant and early child and perinatal mental health for a number of years through home visiting and working with ill children. I'm delighted to be part of this project.
All right, thank you. Thank you, Dr. Zena. And we're going to go ahead and go right into the didactic session. Is Dr. Vincent on yet? She is. Dr. Vincent, do you want to introduce yourself as well? I might have caught her off.
Yeah, hey. No, you're good. You're good. I was actually like just getting set up. So no, you caught me at a good
Sorry
time.
about that.
No, hey, no, it's good to see everybody. I'm Megan Vincent. I'm one of the perinatal psychiatry consultants for PPCL.
All right, thanks, Dr. Vincent. All right, now we'll go right into the didactic. Katie Abear is going to present on perinatal anxiety. So for the next 15 to 20 minutes, this will be your show, Katie.
Okay, hopefully 20, not 15. I have a lot of content, so I will try to skim over it, but hit really important parts. We're diving directly into perinatal anxiety. Oftentimes, you might hear people kind of combining these and just calling it maybe postpartum depression or perinatal depression. And really, they all have their own unique pieces. And perinatal anxiety definitely has its own unique symptomology that accompanies it. So, next slide. We're going to dive into the definition. So, perinatal anxiety is defined as anxiety that is occurring during pregnancy up to 12 months postpartum, which is what we call perinatal, and affects 20% of women, and then 65% of comorbid depression. So, we do see that that is commonly linked. I always think of self esteem too being a big piece of this. If I'm really struggling as my transition into this parenthood journey, then I'm really looking back at myself and how I am doing. And maybe those particular messages that I'm sending to myself can lead to some of that depression as well. But what symptoms do we see with perinatal anxiety? Constant worry, irritability, agitation, fear of being away from baby, hypervigilance, sleep impairment. Next slide. So what is so important in our work with the perinatal population is this clinical anxiety or is it non-clinical anxiety? How do we differentiate this? And, that piece is so important because we do know that we're going to have a level of protectiveness towards our children, towards our health. And that can be normal, but we really don't want to normalize symptoms that are not. So we're really looking at what is going to be that clinical anxiety. And what we're focusing on is functioning. How is mom functioning? So think intensity, frequency, and duration. How intense is the symptoms that they're reporting? How frequently are they happening? And when they happen, how long do they last? And then furthermore, how is it impacting mom and baby? And I kind of put this all in caps because I'm going to say this quite often during the presentation, but we're looking at distress. So how much distress is being caused either on mom's ability to function herself or her ability to care for baby? Next slide. Okay. I thought this was pretty clever. I heard this one time, but if you want to know what someone is worried about, ask them what they're Googling. We know for so many of our clients, maybe they are not reporting to us that they have anxiety, but they're telling us all these other messages. So probably very relatable for a lot of us in practice. Next slide. Okay, so what do you hear sometimes when it comes with perinatal anxiety? Themes that are very common. Maybe baby is sleeping, but the mother or birthing person is not. So we need to make sure that we're screening for mom sleep, birthing person sleep, just as much as we're asking about how baby is doing and how baby is sleeping. Hyper focus on schedules or routines. This is going to definitely link back to desire for control as well. I maybe as mom may be very focused on that schedule because that's predictability and I want to hang on to that. So whenever that's not happening, it can be very overwhelming for me and increase that distress. Maybe difficulty bonding. Of course, not for every person. Some people are bonded beautifully and have perinatal anxiety, but this is something that will come up. That distress is so high that mom is really struggling with being present with baby. And so it's causing that difficulty to be able to connect. Typically, when we see that anxiety and distress come down, we see bonding and all other things kind of improving. Avoidance, the theme of avoidance. I kind of like to say anxiety and avoidance are besties, like they're best friends, because we'll see them kind of go hand in hand. So we're looking for that avoidance. If mom is maybe very anxious about something, she might be avoiding likely doing that particular thing. So maybe we're not reporting anxiety, but we're saying, I'm really struggling with something in particular. And on the right side, I kind of wrote those things that we might hear quite often. I don't feel like myself. Can't enjoy my baby. I'm scared to be alone with my baby. I fear leaving the house. Next slide. Okay. So what are risk factors that we want to consider. You know, it's always beautiful. We can reach someone kind of when they're maybe in the beginning stages of a pregnancy and that prenatal part, but sometimes, of course, that's not always when we meet them. So a prior history of anxiety or depression. So if we already struggle with anxiety or depression, then absolutely in that perinatal period, we want to make sure we're monitoring for that. Previous pregnancy loss. Absolutely, we're going to have maybe some more heightened anxiety. And so we want to watch for that. You know, typically what I will see is that the distress level of the birthing person is pretty high up until that moment when they've had their latest loss. So whatever week that is, they might have higher distress levels. But once we get past the latest area, so let's say they had a loss at 20 weeks, when we get past that, anxiety still may be present, but we hope to see that distress level come down a little bit. Lack of sleep is a risk factor. Breastfeeding or chest feeding challenges, absolutely. Past sexual trauma, we'll get into that. Baby's temperament, you know, baby's temperament is a big one, especially when it comes to our own sensory struggles and our own emotional regulation when baby's not being regulated. And these are things we can't always predict before baby comes, what that temperament is going to be like. The personality trait of perfectionism and complications, whether it be birth complications, an NICU stay, many others, but these are going to be risk factors that we might see more heightened distress levels. What are our protective factors? Sleep and support, guys. These are so incredibly important for our new parents, sleep and support. So really making sure we're focusing in on those two. Education. I don't know about y'all, but just being able to provide some education. I know what this is. I know how to treat this. I'm going to get you to maybe some other services, being able to tell them and identify what it is that they're experiencing, even if we haven't done any other work, can be incredibly helpful. But the same is true of what is not normal. You know, I think in society, of course, social media, we have lots of messages that kind of get misconstrued of what is normal and what is not. And so we want to make sure we're paying attention to our language because common is different than normal. Something might be common, but it doesn't mean that it's normal. And so we want to make that difference for them. Okay. Knowledge, access to resources. We need to have the knowledge that there are resources out there for us, and then we need to know how to be able to reach them and how to connect with them. Okay, next. So breaking this down into the subcategories of perinatal anxiety. These are the four main ones. And when we look at them, we may spend less time really for the sake of time, you know, looking at the definition of them, but how do they show up in the perinatal period? So generalized anxiety disorder, panic disorder, obsessive compulsive disorder, and post-traumatic stress disorder all fall under that perinatal anxiety. Next slide. Okay, so for our generalized anxiety disorders, so this particular parent who's coming in and having this excessive worry, we might see common personality types like our type A personality types. But all over the place, this is going to be your client or patient who is just bringing up lots of overwhelming feelings, but it's at the point where it is affecting their functioning. Our panic disorders can connect with another. So sometimes we see that going hand in hand with some of the other diagnoses listed here, but it can absolutely stand on its own. I can think vividly of cases I've had where they'll say, I'm really not struggling day to day with my anxiety, but I'm having these moments of intense panic. And they can identify these episodes for us. So they're having intense fear peaking within minutes, and sometimes they have no idea what these triggers are that are causing them to happen. But some of the fears that we see, dying, breakdown, losing control, perinatal OCD. This is definitely one that's close to my heart, one that really can terrify our clients because they don't maybe know what is happening and these intrusive thoughts that are present. So when we think of OCD and perinatal OCD, we're having these recurrent, intrusive, repetitive thoughts that are unwanted and very distressing to us. And so it's happening in that perinatal period. These intrusive thoughts are happening and it's causing the mother high distress. So here's that word again, high distress. A mother's coming in and reporting how overwhelming these feelings are. And she's kind of probably also explaining how she's trying to cope with them. And these coping mechanisms are also maybe causing additional distress. We see these categories: harm, contamination, sexual. I would say harm is probably our most common. So either harm, like the thoughts are telling mom or birthing person that either they are going to be harmed, like I might die or something might happen to me medically, or something might happen to my baby. My baby might be hurt. I might drop my baby. So something harm related. Contamination, this would be definitely our excessive cleaning, sterilizing, the process. I've even seen it when it's come to maybe family members who are smokers, and kind of the ritual in which they want a person to feel like the person's maybe very clean before they hold the baby. And I think COVID was definitely one that put a lot of emphasis on this as well. Sexual is one where I'm having these thoughts that are very distressing to me. I'm changing my baby's diaper, or I'm bathing my baby, and I'm having these thoughts that I'm doing something inappropriate and I'm not, but that thought is very distressing. So what we want to get across with this one, high distress, we're going to screen for that OCD. Low distress, if they're not distressed by these thoughts, then that's something different. That would be more psychosis, definitely a medical emergency. Thoughts do not equal actions. Just because we're having these thoughts doesn't mean that this particular parent is going to act on these thoughts. If anything, we're really looking and watching at ways that they're trying to prevent something bad from happening. And then I just wanted to add, not all intrusive thoughts are OCD. I'll see this come up a lot where, it could be confusing. A lot of us have intrusive thoughts at one time in our lives, but if they're fleeting, we're not really going to attach it to OCD. So in the perinatal period, we're really looking at, a lot of checking, measuring bottles, checking on baby breathing, and gosh, so many other examples. Okay. Perinatal PTSD. So this is going to have our typical PTSD diagnostic criterion happening in the perinatal period. We are going to see either there is past trauma that the perinatal period is kind of triggering and bringing up for this particular parent, or it's something that happened in the perinatal period, maybe a birth trauma or something related, a loss, that is creating this PTSD symptomology to occur. I love this quote by Cheryl Beck. Trauma is in the eye of the beholder. And so when they are reporting their trauma, that is so important for us to understand that that is absolutely a trauma. Okay. And one note to make when we're in practice, if you're hearing a lot of language like trigger, this was really triggering to me. Trigger is a trauma word. So, if we're hearing that language, they may not be reporting trauma or using that language, but we would want to kind of go there, because if they're talking a lot about triggers, we want to screen for that. Okay, next slide. Okay, I probably talk with parents about this on a daily basis. So how can we help a new parent differentiate between anxiety and intuition? How important for us to be able to support them in this? My rule of thumb, if I could give some kind of, I guess, feedback, would be, to me, anxiety, or I like to say anxiety is more internal, intuition is more external. So when we think of anxiety, it's something that is going to be generated internally. What are my internal thoughts telling me that's kind of creating this anxiety to occur? Intuition is going to be more external. So maybe you don't know what's happening, but you could tell me something that's making you concerned. Well, my baby just doesn't normally sleep like this. Okay, well, let's keep watching that. That may not be all of anxiety. You're kind of noticing a change. So anxiety is very much internally driven, or intuition, there's something external that's making us concerned. Okay, next slide. All right, so how to treat. of course, screen for, we're all in different settings. So we may not have much time with this particular individual who's in front of us. So we definitely want to use our screens. We want to assess for medication support. Is this something where we're looking at medication as a supportive measure? Psychoeducation, I spoke on that. The importance of being able to tell someone either I know what this is, and I know how to help you, or I know how to get you help, is so relieving to that person. And if we don't know what this is, I'm going to get you to the right person. So some psychoeducation can be very important. We're targeting the distress, though. It's really hard to move forward with a client or patient if that distress is really high. So we need that distress to come down a little bit before, number 5, we introduce any kind of evidence-based modalities. And there's some wonderful evidence-based modalities for perinatal anxiety, CBT work. I love Jeffrey Schwartz and his work with OCD, helpful self-talk, EMDR, exposure and response therapy, mindfulness, grounding work. So all these things are wonderful, but we need to make sure that they are in a place where they can absorb that kind of work. And so we really need that distress to come down. Okay, next slide. All right. I know I have 3 minutes. Our screening tools. So the PASS is a great tool to use. It's very specific. So our perinatal anxiety screening scale, it's a scale that's incredibly specific for anxiety, and it breaks it into 4 categories. So as you can see on the right, acute anxiety and adjustment, general worry, specific fear, perfectionism, control trauma, and then that social anxiety. So that's a great screening tool to use for concerns related to anxiety. The Edinburgh postnatal depression scale, we talked about that last month if you were on with us, but that's that 10-question screening tool. It is highly used and effective in identifying concerns for depression, anxiety, thoughts of harming self. So that's a beautiful one to be able to use. And then the OCI-4, I included this one. There's also the OCI-R, which is the revised version. But the OCI-4 is incredibly brief. So if we're considering, is this maybe some kind of obsessive compulsive disorder symptomology, that's going to be an ultra brief one, depending on what kind of setting you're in. That can be helpful. If you want one a little bit longer, the OCI-R is about 18 questions versus 4. And it's another really helpful tool. Okay, next. So the screening recommendations for timing, that first prenatal visit, once in the 2nd trimester, once in the 3rd trimester, 6-week postpartum visit with OB, repeat screens, OB, PCP at 6 and 12 months postpartum. And then for our pediatric populations, 3, 9, and 12 months. Sometimes you're the one who is seeing mom and baby the most. So that's incredibly helpful when it's happening in our pediatric offices as well. Okay, next. All right, so to wrap up, what are our reminders? There's 3 crucial parts. Detection, we have to see it so we don't miss it. We have to assess for it. And then when we determine that this is something that we need to treat, what are our treatment options? The appearance of a mother or a birthing person has little to no indication on whether they have perinatal anxiety. I often feel like I will hear even my clients telling me, that was the way that they were trying to mask it, keep it together. That's their control. They want to look really put together on the outside, maybe. So that's really no indication that they might be crumbling on the inside, okay? Okay, anxiety and avoidance are best friends. Ask and watch for avoidance. Are we not leaving the house with baby? Are we not wanting to do certain different tasks with baby? Maybe that's bathing, nighttime routine, all those things. Okay, so just really watching for that avoidance. Common does not mean normal, so language is really important. And then I needed to put in somewheres, it's just we don't want to forget about our substance use and abuse. So really assessing for substance use as a contributor, as like maybe an unhealthy coping mechanism. There is that mommy needs wine culture. And so that's really important that we're also screening for substance use as well. Okay. Questions?
Thank you, Katie. We have time. We could do 1 or 2 questions if anyone has any.
It looks like there was a question in the chat. I can read it from Angel. She was asking about risk factor, if they have a history of anxiety and depression. If they have chronic anxiety, how can we differentiate between that and perinatal anxiety?
Mhm. So it's really just continuing within the perinatal period. So likely that symptomology, if she's already struggling, we may, I'm not going to say we always will, but we may see it continue. The the difficulty with the perinatal period is that there's going to be additional stressors and our basic needs get really challenged. So our sleep is challenged and our ability just to be able to make sure we're taking care of ourselves is really challenged because we are dealing with someone so dependent like a baby. So that symptomology may look very similar in the perinatal period as it did before. It just may show up differently. So I would say if there's anything we can do for someone in this period would really be focusing on sleep, making sure that they're getting good rest, they're being followed, especially if we know already that they struggle with anxiety and depression, and that we're putting a lot of support around them.
All right. Thank you, Katie. We're going to roll into the next part of our appreciated.
As we mentioned before, we do need someone to present cases. Is anyone on the call willing to commit to doing a case? Call anybody out? Anybody want to come off mute and just give us or raise your hand and we'll add you to our list and reach out to you? What do you think about it? Our next session,
Yasmin Welch,
Oh,
raising her
yay.
hand.
I was going to say, you're a good candidate to present a case. If listening to the echo, you go, oh, I've seen one of those.
right.
Mhm.
Yes. Okay, thank you, Yasmin. We'll reach out to you to get the next step. But our next session is going to be on Tuesday, May 28th. We do, like I said, we need cases beyond the next one, but we're going to put a link in the chat. Sienna's going to put a link that, I'm sorry, one more, go back. Link in the chat that has the CEU information to complete the survey, but I'll send that out in an email to everyone, and we'll also send the recommendations out, Laura, so you will have a list for you. But our next presentation will be birth trauma and PTSD and by Dr. Kara Brown. So that's our next topic. So thank you for participating. We appreciate, thank you again, Katie and Laura, for presenting. Great discussion, everyone. We'll stay on the line for a few moments in case you have questions, but thanks, and everyone enjoy the rest of your day.
Thank you.
Bye.
Thank you, guys.